Good morning, good afternoon, good evening, ladies and gentlemen, wherever you may be. Too bad we cannot meet face to face, but by license of very good technology, we are able to gather together today to share thoughts, experience, and comments with the title of the session, Minimal Invasive Cardiac Surgery Valve Procedures in 2021, Global Trends and Perspectives. I would like to take the opportunity and thank our host for today, which is no other than Medtronic. Thank you for making this possible. I am Kofidis from the Department of Cardiac, Thoracic, and Vascular Surgery of the National University Heart Center in Singapore. And I'm delighted to introduce our two speakers, both authorities in the field of minimal invasive and robotic cardiac surgery globally. Professor Olivier Bouchot will kick it off and give us a bit of an insight on minimal invasive aortic valve surgery, followed by Professor Balkhy, who will give us insights into the robotic aspect of things and introduce some technology related to a robotic mitral valve repair. I will start off first in a short presentation of the global perspective of minimal invasive heart valve surgery nowadays across the globe. I guess the fact that I find myself on the antipode of the planet in Singapore puts me in a bit of a observer C position, and looking at the adoption as well as penetration of related technology in the market. If I were to ask you, how does the heart team work in your institution? I guess this is how it would work in mine, and that is the fact and reality around the world. Oftentimes, we don't need to doubt who is the lion and who is the zebra, respectively, cardiologists or heart surgeons. And if we heart surgeons would like to survive in this very exciting and meaningful field and not end up like this, I personally believe that we have to adopt new technologies and become something like a hybrid ourselves, a Libra, eventually. Now, when we talk about setting up a minimal invasive cardiac surgery program, my personal recommendation and general perception is that we're talking about a program, not as just a single procedure. It has to be comprehensive, reproducible. It has to entail training, synergies with the industry, academic and educational components, and cover for the most of the pathologies of the heart. I don't want to get too much into the hyperspace theory, but minimal invasive doesn't equal minimal invasive. There are various iterations and permutations of the minimal invasive heart surgery. We mostly start with a manual version, then move on to stereoscopic versions, 3D supported camera versions, endoscopic ones. And then eventually the technically most demanding will be the robotic minimal invasive cardiac surgery, for which we're going to receive a taste by Professor Balkhy coming up. Transcatheter procedures is, of course, the ultimate step, which are performed by the heart team, primarily by cardiologists in the majority of cases. In our institution, we managed to set up such a program step by step and cover for most of the cardiac pathologies to a high percentage, as it's depicted on this slide here. It's well known that minimal invasive heart surgery bears significant advantages over median stenotomy, and at least proves non-inferiority when it comes to the major complications such as stroke and death. We are happy to share that we lead a center of excellence together with Medtronic, hand in hand, and I cannot emphasize enough the importance of synergy with industry as we implement new technologies. Training, education, and simulation plays a growing significant role. Research translation and commercialization, technology, and so on, in particular campuses, is very, very key in order for surgeons to be able to implement new technologies. And synergies with various MNCs around the world will come to complement your quiver as a surgeon to be able to offer the entire spectrum to our patients and implement novelties and technologies in the field. Here, a picture of myself and our cardiologist in the hybrid theater conducting a minimal invasive hybrid bypass procedure. But how does it look around the world? We are not surprised to see that in Germany, that's the yellow graph, there is an over 50% adoption of minimal invasive cardiac surgery. It's mostly European countries which lead the pack, basically, whereby I must declare that this graph did not include, our search did not include the USA at this point. And if you look at Germany, which is really very adoptive for minimal invasive and novel technologies, and you further dissect down what types of procedures are done and to which percentage in a minimal invasive fashion, you will not be surprised to see that the TAVI, transvascular, meaning transfemoral procedures, have the lion's share, followed by AVR stenotomies, and then minimal invasive AVR, partial stenotomies, all with growing trends. Where Europe is not doing so well, in quotation marks, is adoption of robotic techniques. And I look forward to Professor Hussam Balkhy's comments on this phenomenon. The robotic cardiac surgery adoption seems to be stronger in the United States. So where do you stand? Where do we stand? And what does it take to pass through the so-called tipping point and lower the threshold for everybody to adopt obviously meaningful technologies and techniques such as the minimal invasive cardiac surgery platform? One of the aspects that we have to look at as a profession is training. Eventually, we must look into adapting our training to the demands of the times and changing our core and our curriculum. Another formative development is the introduction of hybrid theaters. Now, some of our minimal invasive procedures are difficult to penetrate because they require special technology. Those technologies may be taken for granted in very advanced technologically countries, but in developing countries where lots of structural valve disease exists, these technologies cannot be implemented, and that of course pulls a brake on the penetration of new technologies into the market. However, the prospects, I would say, are brilliant, because all these procedures you see listed here have been reported as anecdotally reported as combined in the past. And new trials will hit the surgical world and market to prove that these procedures can now be done concurrently by the heart team in the hybrid theaters. And with that, I would like to stop here and finish my little introductory presentation and look forward to the presentations of our two very prominent speakers. First off is Professor Olivier Bouchot from Dijon, France, who will share his experience at his institutions on minimal invasive AVR. And without much ado, I would like to now pass the microphone over to Professor Olivier Bouchot. Olivier, over to you.
I would like to thank Medtronic to invite me for the symposium, and would like to present our aortic valve replacement by right anterior minute in Dijon University Hospital. We start our experience in 2009, and to date we operate more than 800 patients by 3 surgeons. The majority of the patients were operated by isolated aortic valve replacement, but in 150 cases we could be a combined surgery with the aortic valve replacement, like ascending aorta replacement, right coronary bypass, left appendage resection. In 5 patients, we perform a dental procedure. Before to operate the patients, we need to have a pre-op screening. The cardiac screening is a classical one, but we take care with the vascular screening. We look for the aorta. We want to eliminate dilatation of the aorta, aneurysm at the beginning of the experience, or more calcification. In fact, we don't want to have this kind of aorta. This is for us a contraindication for the aortic valve replacement by right anterior minute thoracotomy. The other point very important, this is the iliofemoral access for the CPB cannulation. We want to avoid calcification and stenosis on aneurysm or dissections. We could not perform femoral access in this case of cases with iliac stenosis. For that, we use the CT scan, or we can use the duplex scans for the iliofemoral artery. For surgery, we use generally the third intercostal space. We cut systematically the right mammary artery and the vein. We put CO2 on the chest with the 0.5 milliliter per minute. The patient is under selected intubation for the lung. For the CPB, we use the femoral percutaneous approach. We start with the vein under echo guidance, and we done the same thing for the femoral artery to have a very middle function of the common femoral artery. At the beginning of our experiment, we use the pre-closing with the ProGlide, but now we use the Manta system to close at the end of the surgery the femoral artery. The position of the venous cannula is very important. We done this one on the TE control to be sure to have the femoral cannula in the right atrium to the superior vena cava. The venous drainage is very important. We can use active drainage or only a suction of the cardiotomy. We use the retractor. This one is from Coronero, and we open the pericardium and the L inverse shape. After we insert the cardiopulmonary cannula and the ascending aorta, we clamp the aorta with a Chitwood clamp or with a Glauber clamp. We open the ascending aorta and we put a stitch on the upper part just to open the arteriotomy. After that, we put 3 stitches on the upper part of the each commissure, and we pull this one to attract the valve in the direction of the skin incision for direct visions. After we could done classical decalcification of the valve and the annulus. Since 2 years ago, we use the Avalus for this kind of surgery. And this is very interesting because this is a very low profile and we have very good visualization of the annulus when the valve is in place. For the suturing, we use generally the U-stitch with the plate jet reinforced. This is very important to have a very strong one because to avoid some injury of the annulus and to have a very good suture using the cornet after that. Generally, we control the position of the valve with the video, and we tied the knots with the cornet. Using the cornet, this is very an important thing in this surgery, just to be sure to have very strong tight of the knots, because you could avoid to have a paravalvular leak. You can use the push on knot, but sometimes it could be very difficult, particularly on the back of the commissure. The other things, using the cornet, you keep a lot of times of cross-con time, as you can see after. We control, we don't have hole under the annulus, just to avoid to have paravalvular leak. After that, we need to close the arteriotomy to avoid to have some bleeding, because to add some stitch after we have declamped the aorta, it could be sometimes very difficult by this way. When we're weaning the CPB after we remove the cannula with a compression for the vein and the Manta system for the femoral artery. We close the chest very well to avoid some lung hernia. At the end of the surgery, we have skin incision around 4 to 5 centimeters. In our surgery, we can use different type of valve. Generally, this is more bioprosthesis, and now we use the stented valve because using the cornet, we have very secure aortic valve replacement with low rate of pacemaker and no paravalvular leak. We can use different type of stented valve, and the Avalus could be very interesting because they have very low profiles in this surgery. Before we use some sutureless valve or rapid valve deployment valve, but now this valve is not available in France, only for combined surgery for the perceval. In terms of mechanical valve, we can use different type of valve. In terms of suture, for us, the best suture to aortic valve replacement by right anterior thoracotomy is the reinforced U-stitch that we use generally and associate with the cornet. The cornet is the very, very important things in this surgery. We can use different other type of suturing, and the simple stitch could be used on the small annulus. If you look at the cross-count time, for all isolated aortic valve, this is 84 minutes. If you just look at the stented valve, we have 92 minutes cross-count time. But if you use the cornet, we decrease the cross-count time around 75 minutes. And the lowest times that we have, this is with the sutureless or rapid valve replacement with 64 minutes, but with high rates of pacemaker. In conclusion, for us, the aortic valve replacement by right anterior mini-thoracotomy could be performed by all confirmed surgeons, and they could be performed for almost of the patients with only the contraindication for the fragile patient. These patients now generally go for the TAVI, and the other contraindication, this is a calcification of the ascending aorta. We have excellent results in terms of paravalvular leak. We have no paravalvular leak with using the cornet, and the rate of pacemaker is less than 2%. And we have very nice cosmetic results for specifically for the women and also for the man. But this technique, we have a learning curve, and I think this is very important to see a proctor for the training for this technique. And probably in the future, there could be an alternative for the TAVI for the low risk patients with the excellent results. Thank you for your attention.
Our second very prominent speaker, Professor Hussam Balkhy of Chicago, United States, will give us an introduction into the Chicago Robotic Program and Minimal Invasive Repair Program. Dear Sam, we truly look forward to your presentation. Please go ahead.
Good afternoon, everybody. My name is Hussam Balkhy. I'm a director of the Robotic and Minimally Invasive Cardiac Surgery Program at the University of Chicago Medicine. I am pleased to be part of this symposium around the ISMICS 2021 meeting, ISMICS Reimagined, on minimally invasive cardiac surgery valve procedures in 2021 global trends and perspectives. I'd like to thank our sponsors for this symposium, Medtronic, and also thank my co-speakers, Professor Kofidis and Professor Bouchot, and hope to have a great symposium with excellent sharing of information today. My topic is robotic mitral valve surgery, the Chicago experience. These are my disclosures, the most important of which is that I'm an avid practitioner of robotic cardiac surgery. So as Billy Cohen used to say, please take what you hear in this talk with the appropriate filters. I'd like to start with just a perspective of our robotic program in that we use the robot pretty much for most of the cardiac surgical procedures that I do today, and we use it every day. It's not a novelty. It's not a complexity in the operating room. It's a standard and stable piece of our operating room armamentarium. And we published this recently on a shifting paradigm in robotic heart surgery from a single procedure approach to establishing a robotic heart center of excellence. And we use the robot for everything from coronary bypass surgery to intracardiac valvular procedures to atrial fibrillation surgery and all the other indications that you see here. We recently presented at the AATS meeting last month on the early outcomes in over 1,100 patients that had a multi-spectrum use of the robot in cardiac surgical procedures. Robotic mitral surgery is on the rise worldwide. Several large programs in the United States have successfully adopted robotics in mitral surgery and have really, I think, motored that adoption. There have been 7,000 robotic mitral valve procedures between 2011 and 2016, and 11.5% of all mitral valve repair in the United States is performed using robotics. In North America, there are 30 established robotic programs that are performing at least 20 or more mitral procedures a year. And even in Europe, there is a significant growth of robotic programs in the last several years, as indicated by some information that Intuitive has shared. These data are from a recent publication by Doug Murphy, who's one of the pioneers of robotic mitral surgery, in the journal Innovations, where he outlined the efficacy, safety, applicability, training, and financial implications of using robotics in mitral valve surgery. And you can see here the progressive increase in mitral valve volume that Dr. Murphy had seen in his own practice since he adopted the robot. Another publication in the same journal from Daniel Bethencourt talks about the 8 key strategies for successful robotic heart startups, and everything from online modules to simulator training, cadaver procedures, and then aggressive involvement with a proctor and obviously case observations until one is comfortable to proceed. And the Da Vinci robot is extremely well suited for repairing the mitral valve. This has been shown in multiple centers and publications. This is an early one from Dr. Randy Chitwood, who's also the pioneer of mitral valve surgery from 2016. Actually, this was talking about the overview in the Annals of Cardiothoracic Surgery. And I just wanted to allude to the slide that shows the contraindications, which are really in evolution as one's experience increases. And so, for example, patients with poor left ventricular ejection fraction or patients with combined coronary and mitral disease can all become candidates for robotics once the experience increases. And this has also been shown by Didier Lumet and Eugene Grassi, who published this paper recently in the European Journal, talking about the complexity of mitral valve repairs that can be performed robotically, and fully 30% almost of their procedures were complex, meaning significant Barlow's procedure valves, as well as mitral annular calcification, and 24% were most complex with excellent results. So how about our program? Our robotic mitral valve repair program is a truly endoscopic procedure. We use a 12 to 15 millimeter working port with no rib spreading, peripheral cannulation, not yet percutaneous, but hopefully getting there. We use the endo balloon for cardiac arrest or the Chitwood clamp when the endo balloon is contraindicated. The anesthesia team places a coronary sinus catheter and a pulmonary artery vent. We use single lumen endotracheal intubation. No need for right lung blockers. And we do all manner of complex mitral valve repairs, as well as concomitant procedures, including tricuspid valves and cryo on a routine basis, and rarely concomitant TCABs. Mitral valve replacement is also doable with this approach. You have to increase the incision slightly to get the valve in, and then a good 8 or 9% of our patients are redos with previous cardiac surgery. This is the setup that we use, familiar to many people, with the endo balloon, using the endo return cannula, coronary sinus and PA vent from the neck. And these are just images to show these different technologies, some of which are necessary and some of which are not. This is a picture to show confirmation of the coronary sinus placement in the coronary sinus with dye. The endo vent is easily passed, similar to a Swan-Ganz catheter, and can aid in venting of the heart. Today, we actually used it as a superior vena cava cannula, if you will, when we had poor drainage because of a very small SVC. The intraclude is the endo balloon, and is not that hard to master once you've used it several times. It allows delivery of antegrade cardioplegia, vents the root, and monitors root pressure. The CT angiography, I think, as mentioned by most minimally invasive surgeons, is necessary to avoid complications of peripheral cannulation, and we do CT angiography as a matter of routine on our patients. Our anesthesiologists are very facile with providing the views that are necessary for cannulation. This is the bicable view for cannulating the inferior and superior vena cava, and then the aortic view for placement of the aortic balloon and then arresting the heart. Our setup looks like this. This is a 12mm camera port, and then 8mm ports for the arms and the dynamic atrial retractor. And this is our working port, which has gotten smaller as we've gotten more experience. Now it's about 12mm in size. And this is what it looks like when the robot is docked and the cannulation here peripherally. I borrowed this slide from Dr. Sloan Guy, who's actually taken this to another level and uses a totally endoscopic approach. And he presented this as well at the AATS and uses a very small working port, which is an 8mm working port, this air seal port. And I think that's hopefully a goal for any of us that do robotic mitral surgery that potentially could achieve. Here's the Chitwood clamp that can be used in patients with small peripheral vessels that don't tolerate the endo return cannula with an antegrade catheter. I'm going to show you a couple of cases that we did recently. This is a gentleman with bileaflet prolapse. You can see severe Barlow's mitral valve degenerative disease with severe MR. The setup is, as you saw, we get in and place the dynamic atrial retractor, which is very versatile and allows you to see various parts of the left atrium. The suction irrigation device that you see in the right hand here allows for good evaluation of the mitral anatomy. And then once it's clarified where we want to put our cords, in this case, we ended up repairing this with cords to both the anterior and the posterior leaflet. You can see the flail and the torn chordae in the A2 scallop. This is the standard kind of CV4 Gore-Tex neocord placement to the papillary muscles and then to the edge of the leaflet with a figure-of-8 configuration. And the atrial retractor really does allow for excellent visualization of both the left atrial and the left ventricular space. All you have to do is just advance it a little bit and visualize the papillary muscles and the intraventricular aspects of this. So it really does provide for an excellent view here. I like to cut the cords and not tie them until the ring is in, and then we tighten them out just a little bit to see kind of where we're going to stand and what we think of our height of the posterior leaflet in this case. As a preliminary adjunct. There's a PFO that's being closed while we're at it. And then we're going to bring in the ring. This is a partial annuloplasty ring simulus, which I like because it's very easy to use. And I think it's appropriate for most patients. You really only lose about 3 or 4 sutures in the anterior annulus. We bring the tip of it and the anterior trigone all the way up anteriorly in order to have it sit perfectly well. And then we place core knots serially while tightening the suture there. The assistant places the core knots. Once the ring is in, I like to tie the cords after reconfirming the height of the leaflet here. And then finally, once all the cords are tied, and this is an intracorporeal instrument tie, we test again. It looks like we've got competence, but we still have a little bit of a high P3 scallop. And so we're going to add one more cord in this area here to bring it down even further. And then we'll test again and make sure that we've got a good long-term result, because competence at the time of surgery is not necessarily the only goal here. We want to have a long-term result for some of these younger patients that come in with this problem. And so then once we're done, I guess we didn't show the water test again, but we got it to come down. I'll move it forward and show you the postoperative Transesophageal echo, you can see there, excellent result with no residual regurgitation and what looks like to be a very good coaptation service. This is a second patient that I will show you who has severe eccentric mitral regurgitation, and you can see a very flail posterior leaflet. The jet is directed anteriorly, and our reconstruction with 3D, which we've been doing more of these kind of semi-transparent views, shows a really nice picture from the surgeon's viewpoint of a flail P2 segment with torn chordae. And then this is the intraoperative video, where again, we're starting with this irrigation suction device to kind of find out exactly what we're going to be doing. This is a leaflet that looks a little bit too generous to preserve, and so we're going to go ahead and do a resection of the P2 segment in kind of a semi-butterfly configuration, as can be seen here. And the shears are in the right hand, and I generally will use a DeBakey in the left hand and do the excision that way. We use a 4-O-proline, so this is just undermining the leaflet to enable to get a good reduction in height, both towards the P1 and then towards the P3 segment. And then I reconstruct with a 4-O-proline using a 6-O needle, which I think sometimes is a better choice instead of using a large needle. You can kind of wheel it. The assistant is helping with pulling the suture together. And so we're working along the annulus from the P1 side, and then we'll do a second slide from the P3 side, and then bring it together. And then I like to do interrupted sutures to bring the P3 and the P1 together, which you'll see here. It's not hard to do intracorporeal instrument tying. We do it all the time for our coronary procedures where we use a sutured approach. And once you do that a fair bit, it's not, it takes a little bit more time, but I think it's a secure tie and really avoids the tension on the leaflets. Once we have the two leaflet remnants together, we will go ahead and size the annulus, and we'll place the annuloplasty ring as was seen in the first procedure. Here you can see there's a little bit of a leaflet coaptation that can be helped with the ring, and here's the same stimulus, semi-rigid. They call it a band. I like to call it a ring, a partial ring, because it is semi-rigid, and I think the rigidity gives the valve a little bit of structure. And we true size this partial ring in order to, I think, prevent undersizing. And I find that my average ring size is either 36 or 34, 38. It used to be significantly smaller, especially when we're preserving cords. And here you can see, just to evaluate the coaptation service, which looks like it's pretty decent. And the postoperative echoes show pretty good results with no residual MR and no systolic anterior motion of importance. So I'll conclude my talk with that, and I look forward to the discussion with my co-speakers during the symposium and answering any of your questions. Thank you very much.
Thank you very much, Sam, for this excellent presentation. I thank both of our speakers for their impressive presentations. Obviously, they're authorities in the field, and they showed us quite a bit of surgical prowess, as well as a stepwise approach in their respective presentations. Sam on the mitral valve and Olivier on the minimal invasive aortic valve. I would like to address some questions to you, and I will start by addressing both of you, basically, as people who have established minimal invasive heart surgery programs of international weightage. Now, how does the presence of a minimal invasive program in your institution affect the decision making in your respective heart teams? Do you see a swaying of referrals towards more surgery now, or is it a first come, first serve principle? Maybe I start with you, Olivier.
In fact, we started more than 10 years ago a minimal invasive program because in France, you have some pioneers in mitral valve videoscopy surgery. This is like Professor Obadia. And if you want to keep some patients to repair valve, and we need to go on this kind of surgery. And after that, when the cardiologist have some patient operated by minimal invasive, he asks to you for to go to repair the valve with this type of surgery. And I think the first for the surgeon is to change the mind, because now we know with the cardiologists, they push for the real minimal invasive with the TAVI and the mitral valve repair with mitral PIP. And if the surgeon keep the surgery with the full sternotomy, it's probably lose many patients, because if you don't modify our surgery with more elegant surgery, and for the post-operative patients, it's better to have minimal invasive.
So Sam, in your practice, obviously you touch the very extreme end of a difficulty scale by doing complex combined robotic procedures. What is your experience? What would you say? Do you have to educate your cardiologists?
I think this is a great discussion, and I think you're really touching upon some very, very important concepts in minimally invasive. We like to talk about the technical aspect, but I think the global perspective that this conversation is bringing to the fore is extremely important. So I will tell you that I've been practicing minimally invasive cardiac surgery probably for almost 20 years now. When I decided in my early career that doing traditional sternotomy and arrested heart surgery was really not going to be the future for me. And I got myself to understand how to look at the heart from the side as opposed to from the front. And that was a big, big transition in my thinking. And I have many, many experiences with many, many cardiologists and a couple of different institutions as to how that played into the mindset of the cardiovascular team. And I'll just speak briefly about what I have now at the University of Chicago Medicine, where the minimally invasive program, and specifically the robotic program, has been able to bridge the gap between the totally percutaneous approach that our interventionalists use and the totally open approach that our heart surgeons use, and having a robotic middle of the road, less invasive, but also surgically effective approach is very, very helpful. And one quick example of that is our hybrid coronary program. When we look at patients who come in for coronary revascularization, we have a hybrid program between the heart surgeon, myself, the robotic surgical team, and the interventionalist. And we customize the therapy not only for each patient, but for each artery, for each target. And so we do all manner of, single vessel, multi-vessel TCAB, simple stenting, as well as complex CTO stenting. And so each patient gets evaluated on a very, very customizable basis. And that is truly the sense that the heart team should bring to the table. And I think if you have a minimally invasive program, you can really affect it. Otherwise, we're two different silos working separately.
Look, we are all three of us at an advanced stage of our minimal invasive program. Now imagine there is a surgeon who wants to adopt minimal invasive cardiac surgery in his program and help it thrive. What would be the one sentence advice or learning point that both of you would like to give to our audience to take home? Professor Balkhy?
I guess obviously it's hard to distill it into one sentence, but I think if there was one thing that it would be more helpful than any other would be to do it for the right reason, and do it because you want to help the patient get through what we know is a very, very difficult time, which is undergoing heart surgery. And so if you do it for that reason, not to get more patients, not to look cool, not to have any other motivation other than trying to lessen the invasiveness of what you already know how to do through a sternotomy. And if you keep that as your goal and as the top priority, everything else I think will come. And as a secondary statement, I would say find a proctor and somebody who you can rely on, that you can show some of your early cases to, that you can, touch base with and exchange ideas, and kind of, because there's many different ways to skin the cat. And if you choose a method and or an institution and or a proctor that you have faith in and have confidence in, that can be your kind of line to moving forward quickly and safely.
And over to you, Professor Bouchot.
The problem, for example, is you look at for the artificial replacement, and the future is for the TAVI, and probably you have some patients who could go for the artificial replacement, surgical replacement. But if you could not propose something modern, I think the patient go for the TAVI, and the cardiologists prefer to send the patients for a cardiac surgeon who perform small incisions with good results. And if you don't have this kind of solutions, it's probably the cardiologist could send the patients to the TAVI for the low risk patients. And I think actually we have the gray zone. We don't know exactly where is the limit for the patient for the surgical approach, for the TAVI approach, but probably in the future you could include the type of incision of approach for the surgical approach. If you have only a sternotomy, and probably the patients go more for the TAVI. And for this moment, we have better results in terms of pacemaker, in terms of leak, in the surgical approach. But probably in the future, the TAVI increase our results. And I'm not sure we have more patients for surgical artificial replacement. And if you don't have something more less aggressive, I'm sure we don't have patients for the surgery.
Well, thank you very much. I think that's a great note to conclude the session with. I wish the discussion could go on forever. There's a lot of more detail to discuss here, but we have experienced two authorities in the field through great speakers sharing their experience with us. A lot of insight to absorb. Now, it was a very impregnable, sweet, but powerful session. We thank Professor Hussam Balkhy of Chicago. We thank Professor Bouchot from Dijon, France, for their contribution and their presentations. I'm Theo Kofidis from the Department of CDVS in National University Hospital in Singapore. We'd like to thank Medtronic for putting this together. And I guess this is the final and concluding message to our audience. This session is supposed to lower the threshold for our audience to start their minimal invasive program. And I'm sure the esteemed speakers of this session will be at your disposal in one or the other way. We hope to catch up soon, physically, face to face, and to see you all in the not too distant future. Thank you very much.
Thank you so much.
Thank you. Enjoy ISMICS.